Okay, welcome to today's webinar from the Agency for Healthcare Research and Quality. I am Ron Hayes, a CAHPS principal investigator from the RAND team and the moderator of today's webcast. You are about to hear how patient-reported experience measures and patient-reported outcome measures contribute to a comprehensive view of patient care and deliver actionable insights to support quality improvement. The acronyms are PREMs and PROMs. Today's slides are available at https://events.westat.com/CAHPS/webcast. If you have audio issues on your computer, you can listen to the webcast audio on your phone by selecting the Call Me option. You will be prompted to enter your phone number to receive a call from Teams. Or you can click Phone Call to get the dial-in number and meeting ID. If your computer freezes, try logging out and back in. To ask a question, select the Q&A icon, enter the text, and click the Ask button to submit. We encourage you to share your name and organization when you submit a question, and today's speakers will respond to them later in the webcast. The raise hand and chat features are disabled. Next slide. So we will begin with a welcome from AHRQ and a brief overview of the Consumer Assessment of Healthcare Providers and Systems, CAHPS program. Two presentations about PREMs and PROMs will follow. We will conclude the webcast by answering questions from our webinar attendees. Next slide, please. So I'm pleased to introduce today's speakers. Aruna Jhasti is a health scientist administrator for the CAHPS program at the Agency for Healthcare Research and Quality. And both Eugene Nelson and Brant Oliver are professors affiliated with the Dartmouth Institute.
Thank you, Ron. Welcome, everyone, and thank you for joining today's webinar. Today, I'll provide a brief overview of the Agency for Healthcare Research and Quality and share some background information on the CAHPS program. Next slide, please. AHRQ is a research-based agency within the U.S. Department of Health and Human Services. It is the lead federal agency responsible for improving the safety and the quality of the U.S. healthcare system. AHRQ generates research tools and data using best practices that healthcare providers and policymakers use to evaluate and improve the quality of care delivered to patients. AHRQ is not a regulatory agency. It does not set or enforce policies related to reimbursement, payment, or compliance. AHRQ also does not require the use of CAHPS surveys. Requirements for implementing CAHPS surveys are established by other federal and private organizations. Next slide, please. AHRQ CAHPS program has been around for 30 years and has advanced the science of measuring and improving patient experience. And this includes validated surveys for high-stake purposes, supplemental questions, including narrative items, quality improvement resources, databases for selected CAHPS surveys, and research to advance the science of patient experience measurement and improvement. We have deep expertise in measuring and improving patient experience, and we provide support to various activities of the CAHPS surveys users. All the tools and resources are available in the public domain. Next slide, please. All right, so what is patient experience? Patient experience refers to what actually happens to a patient in a healthcare setting or with a health plan, or how often something happened. It includes a range of interactions that patients have with the healthcare system. And this slide shows some of the elements of patient experience that are measured by the CAHPS surveys. These are domains that are important to patients, and they are regularly updated to reflect changes in the healthcare delivery process. Next slide, please. CAHPS surveys are considered as the gold standard for patient experience measurement because they capture the patient's voice. CAHPS surveys reflect what patients told us is important to measure and report. We use a standardized methodology and research findings to develop valid and reliable surveys. The survey items are extensively tested with patients to make sure they're relevant, clear, and easy to understand. And as I mentioned earlier, all the tools and resources are available in the public domain. Next slide, please. So there are a variety of CAHPS surveys. Some CAHPS surveys ask about patients' experience with healthcare providers such as doctors, clinics, and hospice teams, or with care for specific health conditions. Other surveys ask enrollees about their experiences with health plans and related programs. Finally, there are several surveys that ask about experiences with care delivered in facilities, including hospitals, dialysis centers, and hospital outpatient surgery departments. Next slide, please. And now I'll turn this over to our next speaker, Eugene Nelson.
Well, I'm delighted to be with you today to discuss how to understand PREMs and PROMs and their integration. Next slide. An opening thought is that experiencing illness and receiving healthcare is a journey. It may be a short, easy hike or a long, hard trek. Think of acute problems, short term. Think of chronic diseases that last for a lifetime. Integrating PREMs and PROMs into this path forward can improve both the experience and the outcomes of the patient's journey to heal and to go on to live one's best life. Next slide. I'll cover 3 points in this brief presentation. What are patient-reported experience and outcome measures, and why are they essential for delivering person-centered care? Second, what are the current uses of PREMs and PROMs in healthcare, in the healthcare system? And very importantly, how does combining PREMs and PROMs provide a more comprehensive picture of care that reflects vital data to measurably improve the experience and outcomes of care? Next slide. This was just covered. Here's a brief description of PREMs and PROMs. PREMs experience. Patient reports about their experiences seeking and receiving healthcare, such as access, courtesy, and respect, communication, and care coordination. That's PREMs. PROMs, on the other hand, patient reports on their health status at a point in time, like symptoms, physical function, social function, emotional well-being, mental health, and general health perceptions. Next slide. This is a good description that AHRQ has provided to give us a more rounded picture of PREMs and PROMs. PREMs, healthcare organizations, including hospitals and medical offices, can gather feedback about various aspects of patients' care experiences using PREMs, such as the CAHPS surveys. They assess a wide range of patient experiences, such as communication with clinicians and staff, courtesy and respect, access to care, care coordination. Healthcare organizations can use PREMs to monitor and evaluate the quality of care provided, identifying strengths and areas for improvement. Moving to PROMs, they assess patient health outcomes, such as pain, fatigue, mobility, depression, overall health. These measures are often used to assess the effectiveness of treatments like knee or hip replacements or spine surgery. And this is done, importantly, from the patient's perspective, the horse's mouth. PROMs can also provide evidence on which treatments are most effective for specific patient groups, ultimately helping achieve positive health outcomes efficiently. So this is a way of understanding what treatments work best for what kinds of people under what conditions. Next slide, please. So my sense is that PREMs and PROMs are essential tools for guiding and delivering something we all strive for, person-centered care. Why PREMs and PROMs? Using them, PREMs and PROMs, provides a high-leverage tool to guide the delivery and improvement of person-centered care for each individual person. They clarify and amplify the patient's voice by using measures that matter. Next slide. Now, how do PREMs and PROMs fit in the healthcare system? How are they used? I'll show this using 3 models. Let's start with Dunabedian: structure, process, and outcomes. PREMs are used to measure the patient's experience of the process of care, process of receiving care. And PROMs are used to measure a key output, outcomes after receiving care. The outcomes can be general or condition specific. Next slide. The Dunabedian model is very simple. This is a fairly complex model, one of my favorites. It's based on Deming's work, W. Edwards Deming. And this is a comprehensive and a bit complex model. It starts on the upper right with understanding what the social, health, or community need is in our world. And then what's a vision for meeting that need that would actually work in the real world? Now, how do we make a plan to improve to meet that need based on the vision? Then we start design and redesign. And there's the core value chain at the bottom: suppliers, inputs, processes, outputs that are received by patients and families in our world. And what's popped out here is on the bottom line that PROMs is a very good way to measure the input of the individual receiving health care. What is their health status? What are their wants, needs, and concerns? And then PREMs are used to get the patient's, the individual's view of the goodness of the process of care that is meant to serve them and to help them to heal. And then PROMs, as care unfolds, short-term or longer term, are repeated to show the outputs of care with respect to the goal of better health outcomes, better quality of life. So that's the Deming view and where PROMs and PREMs fits into that, and very, very important. So you can look at the results in the bottom against the need at the top. So PREMs and PROMs are used to measure goodness of processes and outputs based on patient reports. Next slide, please. A third model is a value compass model. And this starts on the left-hand side with an individual at time 1. We'll call it time 1. And that individual has a clinical status that can be assessed, a functional and well-being status that can be assessed, prior care experiences and expectations for what good care would look like, and sunk medical care costs, direct and indirect costs of poor health. And then the journey, we pick up the journey: visit 1, visit 2, perhaps a hospital stay, perhaps an ED visit, visit N. And then at time 2, we can look again at the change in clinical status, the change in functional status and well-being, to look at the care experience, the goodness of it, through the eyes of the person served, the patient, and what were the costs to achieve those outcomes. So PREMs and PROMs in the value compass world are used to measure the goodness of care experience, the east compass point, and the evolving functional status and overall health and well-being, the north compass point, over time based on patients' reports and ratings. Next slide. Question: how are PREMs and PROMs being used today? Here are our 5 uses. First, to promote co-production and patient activation, and using this information to feed it forward in the flow of care. You'll see examples of that. To measure care experience, health outcomes, and to contribute to value measurement, feedback to improve and innovate. To provide comparative performance benchmarking for learning and improvement. How does this group's or system's patients with this condition compare in their outcomes and care experience to other places that serve similar patients in different parts of the world? To contribute to health services and translational research. And 5th, to promote transparency by public reporting on patient experience and health outcomes. Those are 5 key uses. Next slide, please. So now we'll go to a case to demonstrate the integration of PREMs and PROMs with the aim of improving care and outcomes. Next slide. This is a case from Transplant and Cellular Therapy Program at the Dartmouth Cancer Center. And it was a combined effort from the team, the TCT, Transplant Cellular Therapy team, and folks in the Dartmouth Institute. Next slide. The aim of the program was specifically meant to improve patient engagement in care, to improve shared decision-making, and to improve symptoms and other outcomes. PROMs data are collected over time, and PREMs data are collected over time at the end of the visit. So first, there are agenda-setting questions when the person visits the CTC team, and to find out what's most important to that person at that time that they wish to talk about. And then what are some major personal goals or values you want the team to be aware of? That's a verbatim, person's own words. And what's been going well for you in the last week? Another verbatim, their own words. So that sets the context and what's on the individual's mind. And then Promise 29 is completed, pre-infusion at 1, 3, 6, and 12 months. And the distress thermometer is completed annually. PREMs are completed at the end of each visit, and the focus there is on shared decision-making using the measure Collaborate, and a post-visit survey that has CAHPS questions that is administered by Press Ganey, and that's done through a patient portal. Next slide. This is really important. You won't be able to see this given the size of the print and all, but this is a point of care dashboard that if I'm seeing Dr. Ken Meehan, for example, and I'm a CTC patient, we look at this together during and use it during the visit. So in my own words, what are my visit goals? How are things here? Excuse me. How have things been going? What matters most to me? Those are all verbatims. And then we get into symptoms, anxiety, depression, fatigue, etc. Now, at the point in time using the Promise 29, and my symptoms over time, so that you can see if a person is improving or is getting worse or staying the same. And the lab values are shown as well. So this is essentially part of the clinical record and a fundamental part of the visits that are made by CTC patients when they're seeing their clinicians and care team. Next slide. This program started in March of 2022 to use this feed-forward PROMs and PREMs data system and use it at the point of care as well as for other purposes. As I mentioned earlier, shared decision-making was a primary goal early on. And in March 23 of 2023, a specific project was started to improve shared decision-making with each patient as they made every visit. And you can see that there was an improvement from about 80% up to actually 100% by June of 2024. So that special effort to really focus on shared decision-making was working well. Patients comment, just helps me feel like I'm part of the team addressing my health, 66-year-old woman. The visual helps to see and discuss trends, 72-year-old man. Next slide, please. This is a bar chart showing the perceived value of the dashboard based on patients' ratings. And this shows the proportion of people agreeing with important statements such as 90% agreeing with information was useful during discussion, 79% agreeing helped me talk about what matters most, 77% agreeing it helped me make healthcare decisions, 30% information changed the focus of the visit, 61% helped me create a care plan I could act on at home. Another quote on the left-hand side from a 74-year-old man. I believe in the guiding principle that I am in charge of my healing. It increases my trust and confidence. It reinforces the gratitude and connection that is so helpful in healing. Next slide, please. Okay, we're going to wrap up. We have the opportunity to mainstream the uptake and use of PREMs and PROMs for this individual person, for this population that we hope to care for improvement, innovation, and research. PREMs and PROMs can supercharge the improvement of experience, outcomes, value, equity, transparent public reporting, value-based payment, health science research, and more. Next slide. Final words. We're in a helping profession. We aim to help people to improve their care experiences. PREMs helps us do that. To stay healthy and to heal and to live their best life. Health outcomes. PROMs helps us do that. Next slide. So Professor Brant Oliver will take you deeper into the subject, how to use PREMs and PROMs to improve healthcare. Before turning it over, just some acknowledgments. Next slide. I'd like to thank many people, in particular, Paul Batalden, longtime colleague, Dr. Ken Meehan, the leader of the CTC program, Brant Oliver, whom you'll hear from next, and Erica Van Sitters, one of the key people in the project that I just discussed. So thank you for your time. I look forward to Brant's comments and to question and answer.
It's a pleasure to be with you all, and thank you for having me again. The web link on the bottom of this slide takes you further into a lot of the examples that I'm going to discuss in my brief segment today, which will focus on real-world applications and with a focus on improving human experience in healthcare. And that website will also list a number of people that have been involved and should be acknowledged with the work that I'll share today. So again, thank you for being with me, and we can move to the next slide. So I'm going to briefly start by framing here. I am a healthcare improvement scientist, and I focus on the area of care experience, improving the lived experience of patients, families, and healthcare teams, and especially using learning health system methods, such as many of those Gene covered in his segment previous, use of feed-forward and feedback data to help us to bring patient voice into the care process, and also to use patient voice to help us to monitor and improve our processes in order to improve the experience of care. Of particular interest to me, and a focus of the first article on the left, an editorial is writing about focusing more on the people engaged in healthcare systems, is that a majority of the work in learning health systems is focused on the mechanisms and data flow pathways in them, and less so on the experiences of the people within the healthcare systems. And PREMs and PROMs are a tremendously powerful way to increase the focus on the people within learning health systems that we are trying to serve, and the care that we are trying to improve to better serve them. And work in the human experience field, which is dedicated to the lived experience of people engaged in healthcare, and has proposed value arguments that rely heavily on the lived experience of care to help us to understand the value of care from the perception of the people engaged in it. Again, patients, families, and healthcare teams. And patient-reported experience measures and outcome measures are a very powerful way to inform our understanding of how a focus on experience can improve the value of care. Next slide, please. In my brief segment, I will describe 4 use cases in which, especially the focus on experience measures, can make a difference in understanding the lived experience of people engaged in healthcare and how to improve it. The first is the use of patient relations information. When patients and families call into health systems that to describe their experience, sometimes with compliments and sometimes with complaints. The second is using narrative data, using AI-assisted approaches and real-time rounding approaches. So examples 2 and 3 will focus on that. And then the fourth is to use experience information and patient-reported experience measures to inform improvement efforts at scale within a health system. That will be the example provided by number 4, the Care Experience Collaborative. Next slide. So the first use case will focus on the use of narrative data as reported by patients and families when they interface with a health system that either have something really positive that they experienced and want to share with us and thank us for, and also the opposite when they had an experience that was difficult and want us to work on. Patient relations units are present in healthcare systems almost universally and exist to work with patients and families around concerns that are reported. And it can provide information about patient and workforce experiences very close in time to the actual index event. People will often call in with concerns the day after or the day of an event that occurs. This data is often qualitative, but it can then be thematically analyzed, categorized, and also counted, which allows us to do mixed methods analyses of the data to inform strategic action or improvement action. Next slide. Here's an example of the use of a mixed methods approach on the data received by a patient relations unit in my health system. It's been de-identified, so you don't know which particular unit we're looking at. But this is a sample report that both the operations team in that department and also our care experience teams can access in a monthly basis. And this categorizes the different narrative comments and concerns that were received by their category. And this helps the teams to prioritize the focus areas for service recovery, and also from an improvement perspective can help us to focus areas for process improvement change or system redesign efforts to help us to improve the care experience. In this particular case, you can see that a majority of the concerns reported by patients in this particular service unit in this quarter focused around care and treatment aspects of their experience, communication aspects, and care coordination and accessibility aspects. A number of these aspects have popped up in previous presentations as very important aspects or important drivers of care experience. Next slide. We can go further with this type of approach to actually apply things like Pareto analyses to help us with strategic planning at the health system level, and also if we're engaged in improvement-oriented activities to target the areas for improvement in places where they're likely to have the most impact. This is a study conducted on just over 4,700 patients in our health system during a time when we were formulating our system strategic plan for care experience. And these findings here helped us to prioritize our strategic plan and put resources and improvement efforts in place to target the top 80% of the factors contributing to care experience difficulties in our health system. And that perpendicular box drawn in there and shows where the 80% cutoff is in our Pareto chart, with the bars in red showing the factors contributing to that 80% contribution. Inside the boxes, one of the comments we analyzed, the receptionist rolled her eyes and laughed at the preferences I shared regarding dates and times so that my husband could also attend this important appointment. That was a comment in our top category, staff office response and communication, our strongest area requiring attention for improvement at the time that we did this study. Next slide. We also looked at the other angle on this, the positives. Positive deviance theory is an improvement theory that stipulates that we can improve by fixing things that are wrong, but we can also improve by identifying the things that are great and amplifying and spreading them. And we wanted to learn about that by conducting a similar analysis on the things that were positives. These were things that patients found so great in their experience that they called in to tell us about it. The top category there was going above and beyond to provide compassion and care. Other factors contributing to the 80% factor contribution here in the Pareto analysis also included factors we just saw in the complaints analysis: communications, the care team working well together, a supportive environment, and a sense of competency. So these positives also helped us to see where we were doing really well and where we might be able to scale and spread the positive things that we were doing. Next slide. In the next use case, I'm going to talk about using AI-assisted narrative analysis to better utilize and leverage the narrative data that we receive. And in this case, the narrative data that we receive is coming to us through our AHRQ and CAHPS surveys from the narrative response options in them. And prior to the use of this approach, we were reading individual comments as they came in on our monthly data reports from our surveys. And we didn't have a way to quickly categorize these findings and also to link it to our quantitative data from our AHRQ and CAHPS surveys. And a thematic analysis for any of you who have been involved in doing this in your own careers and practices, doing by the traditional way, can take a long time to do. So it's very slow and also requires us often to use a low sample size in order to complete the analysis. Using a technology-assisted approach allows us to take a much more volume of narrative data and to more quickly thematically analyze it, which is a great advantage for large, especially in larger health systems. We have a lot of comments coming in, and it can be overwhelming to both leaders and also scientists that are researching this to get a handle on it quickly. AI-assisted analyses is one way to do it, and it also allows us to drill down from a macro level. We can stratify out by different hospitals in the session, and you can go to the next slide. That's okay, thank you. And also to stratify by certain factors that we know are drivers. This is an example of a thematic analysis generated by our narrative system at Dartmouth that shows both positive feedback comments in green and negative comments in red, categorized by key categories such as nurses and physicians, experiences related to tests and treatments, meals, cleanliness, burden of care in the ease and effort category, medications, admissions, and responsiveness. And there's other categories not shown here just for the ease of the display. I showed these here. And you can also see that there's these bars in tan here. These are the benchmark ranges for 75th percentile or greater performance based on the total population of all analyses conveyed by all systems participating with this particular data bundle. So in the case of what we're looking at here, we can see that there's some areas of strength and weakness, but in all of the areas for this particular sample, we're not yet achieving that 75th percentile benchmark based on where we are right now. It helps us target areas for where we would improve. If I click on the different areas, it'll allow me to drill down to different units and also the different, if I want to compare facilities within the health system, I can do that. So let's go to the next slide. The third case is experience-based rounding. This is where we actually interview people during their or just after their care experience, whether it's outpatient or inpatient. Using real-time rounding is evidence-based. It improves quality, safety, and experience outcomes. And technology-assisted rounding can accelerate feed-forward data action and customize aggregated feedback data to inform improvement. Next slide. Here's an example of a real-time application. This is from our Patient and Family Voices program, which interviews patients during their inpatient stay. We're able to aggregate our data on the left to see the volume by which the rounding is occurring. And in the circled areas, those are special cause signals showing improvement in performance in nurse leader rounding during those areas circled. And we can feed that data back to help those teams work on improving their rounding. And we can also see if we're moving the needle on some of the areas we're trying to improve, like the lowest graph here, where we improve provider explanations percentage over time. The report on the right is an individual feedback report that can be provided right after the rounding to people in the units to help them to identify and address issues in very close to real time, which helps us with service recovery and also to even prevent problems sometimes. Next slide, please. Our volunteer rounding program is a highlight of what we're doing currently at Dartmouth. And a volunteer workforce actually works in partnership with our nursing teams on the units to help optimize the care experience for people while they're in inpatient care. And there's a quote here from the nurse leader here about the value that she sees in the rounding approach. She comments that it helps her and the staff hear about stories and concerns directly from the patients and as close to immediate as possible response to it. Next slide. A quick case on this is a patient here who we're not identifying, and this is not the actual patient that is in the story, but let's just call her Martha. And our real-time rounding team, through rounding with her, identified that she was hard of hearing, which the improvement that the clinical team did not actually have recorded in the health record. And they were treating her in her clinical encounters as if she had normal hearing. And it turned out that she couldn't understand anything that was going on. And through this experience rounding and quick follow-up, they were able to notify the nursing team of this and in real time change that status so the healthcare team could now appropriately address her hearing limitation and do much better in communicating with her. And the rounding team then will follow up the following day, and she reported a much better care experience and was very thankful that we had listened to her and helped give her care. It's a very simple example, but a powerful one. Next slide, please. We can also thematically analyze these concerns and create causal models for what things are driving the experience of care in these localized settings and feed that back to teams so they can use this to improve. And just forward it one more. And we can also conduct Pareto analyses to help us target the biggest areas that are going to drive experience most strongly. If we have limited time and resources, which ones are going to give us the strongest impact? These analyses help us. This all came from our real-time rounding data. Next slide, please. Finally, I'll conclude with an improvement example. This is from the Care Experience Collaborative, part of our Promise Partnership Co-Production Learning Health System. And it features a use of PREMs to inform real-time improvement at scale across a health system informed by PREMs measurement. PREM data metrics that matter and feedback data pathways can be selected to align with known priority drivers of experience outcomes. And we use a point-and-click visualization approach to provide one-click access to data so that participating improvement teams and health system sites can monitor their performance and use the data to inform improvement. Next slide, please. This is an example of how we organize the collaborative. On the left are different work streams and improvement efforts. They align with our strategic plan drivers of experience shown in the middle boxes. And then we align those with known drivers of experience outcomes on the right. And these four in particular were a priority for us based on our internal assessment of performance. And the theory here is that if we could organize our local efforts at scale to address one or more of these drivers at each site, that cumulatively at a system level, we could drive attention to all of these drivers and improve the goal in purple which is improved inpatient experience, which we were measuring with overall rating of hospital, and improved outpatient experience measured by likelihood to recommend. Next slide. Here's an example of our real-time feedback dashboard. It's a Tableau interface, real-time point-and-click access on a single link option. It's searchable, so you can look at any one site or all of the sites together, and you can see the overall rating of hospital dashboard shown here for inpatient experience in the big graph, and then on the other graphs here, a number of the very important driver conditions for experience as well. These are using statistical process control, which helps us to identify non-random variations, such as the one circled in red for restfulness of hospital environment, showing some improvement there across the system in the time period circled. Next slide, please. Finally, these things can generate meaningful improvement. After many years of difficulty moving experience performance, this collaborative effort over a 1.5-year period generated a statistically significant system-wide improvement in likelihood to recommend performance, as shown here. If you click it forward just a little bit, it'll show when we started the improvement work, and one more time will show that it resulted with a large upward shift in performance data that is now sustained for over a year with improved performance in that area. So we split the control chart to show it there. So early evidence that these improvement approaches can improve experience at scale. Next slide, please. Finally, I'll conclude here before we go to questions and discussion that these examples have tried to illustrate that we're using a combination of quantitative and qualitative data to inform improvement and strategic planning in different ways. And a number of them show great promise for making a real difference for the lived experience for patients, families, and healthcare teams. Thank you very much.
We're running out of time, so if you can answer this question quickly, it would be great. We only have this one question. What is your organization's biggest challenge in integrating PROMs and PREMs? And in the pop-up, if you can select the one response that represents your biggest challenge in the next 20 seconds or so, that would be great. Well, if we just go with the quickest responses here, we haven't started integration yet, but the next most common choice is data collection and patient engagement. So that may relate to one of the questions we get to. I mean, in the interest of time, I think we should go on to the next slide. Okay, so now we have the question and answer portion of the webcast. And as a reminder, you may ask a question through the Q&A feature and hopefully list your name and organization when you submit your question. And we haven't gotten very many questions so far, so we're going to start with a question that came in before the conference when people registered for the webcast. So for both Gene and Brant, this is a relevant question. Can you say any more about successful integration of PREMs and PROMs into EHRs? Whoever wants to take it.
Brant, why don't you start?
Sure. I've talked a lot, so I'll give a brief example. During the pandemic, we established the long COVID clinic at Dartmouth, and we use a learning health system structure as part of that. And we integrated PROMs and PREMs into the clinical care flow pathway, integrated in the EPIC workflow. It included pre-visit questionnaires, informing point of care, and also real-time feedback at aggregate to help the clinic population with their population management, but also with real-time improvement efforts. And all of it was integrated in the EPIC environment.
I'll add a couple of things that when I get started in trying to integrate PREMs and PROMs into AHRs, I usually start by identifying a well-respected clinical champion for that population of people served. and identifying and working over time, if possible, with somebody who's a senior in the electronic health record team. We have an Epic electronic health record because we know that it's going to take the influence and skills of a well-respected clinical champion, and to get the time of the HR staff to do the programming that's required to put this into the flow of care and to create the kinds of feedback reports that you saw me show and that Brent has shown is really critical. And it also helps to understand how this program ties to the overall health system goals. What's their strategic plan? How are you helping them at the CEO office and board of trustees by working on this? And then the third thing is the idea of co-design, and to make sure that you have a really good co-design team that includes, as mentioned before, clinical champions, important clinical team members, patients, family members, experts like Brant in how do you create an information environment that will actually work for you. And so getting a lead team for conceptualizing, designing, testing, and implementing the new system is really helpful. And learning from others that have done this successfully so that you don't have to reinvent the wheel.
All right, thank you. So let's go on to another question. How might mixed methods strengthen the use of patient-reported information? For example, Brant mentioned narrative information and using that, and maybe Brant, you could either one to answer this question.
Thank you, Ron, and happy to. For us, bringing in narrative data helped us to answer the questions of how and why when we identify changes in what is happening and the magnitude to which it's happening, which the PREMs and PROMs really help us to assess. We can see how well with those that we're doing on our performance levels and how those are varying over time. And we can benchmark in various ways using those measures because they're so well validated and quantitative. But oftentimes, once we detect that, we have questions about, well, how is that happening in a certain setting and for what people and why might it be happening? Adding in the narrative data can help us to answer both sets of questions. And we found that it accelerates the ability by which we can take action meaningfully by having that additional information, by putting them both together.
Great. Okay, a third question, and I want to start with a quick response to it and then let Gene and or Brant also say something. How can you improve response rates to get the best picture of the overall experience to drive outcome improvements? And the thing I wanted to start with was that there are quite a few publications within the CAHPS team on improving response rates, and I'll just mention a few of them really quickly. One was published in 2016 in Survey Practice, and these references are available to anyone who wants them later, but it sort of was an obvious one in that incentives improve response rates by 7 percentage points. And that was a study we did with Kaiser. And then in 2021, there was a study focused on Medicare patients, and it showed that surveys with more supplemental items and less attractive layouts had lower odds of response. And the difference between the most favorable and the least favorable survey design was about 14.5 percentage points. And then another paper in 2022, which was a review of the literature, emphasized the importance of multiple modes of assessment. So not just mail only or phone only, but mixed mode. And you have improvements of 13 percentage points if you have a second mode of data collection. And then on top of that, if you add web mode, it goes up by 2 to 5 percentage points. So that was a big point. And then I'll just mention that there's a JAMA Health Forum article in 2024 that looks at survey protocols, response rates, and representation of underserved patients that you can look at yourself later. So Brant and Eugene, if you want to add to anything here on that question, would be great.
Gene, would you like to go first?
Go ahead, Brant. I'll back clean up.
Oh, okay, sure. We actually attempted one of the things that you had mentioned, Ron, by reducing the survey burden. We found a benefit there, just as was shown in your study. We also introduced multimodal surveying. When I came into the role, we were just using paper-based surveys, and we weren't using text messaging or phone or internet or email-based area options to reach out. So now we're implementing that. In many cases, that can improve response rates also. And we're hoping we'll reach people that we weren't reaching by only using a single modality. So that's another strategy that we're attempting currently.
Great. Gene?
Good responses. One thing that we found effective is to actually make it a policy for a program from the leadership that will do everything possible to maximize the feedback that we get. And then for the leaders to share the kind of information that Brant was showing on participation rates and the results. And then to actually demonstrate the value by doing improvement or innovation projects that move the numbers. But another thing is if we're wishing for a person to complete a questionnaire in the outpatient setting, is a three-step approach, and send the survey out in advance in oftentimes multiple modes to get people to complete it in advance. They show up and they haven't completed the survey. They have a laptop, computer, and they complete it there and then before seeing their clinician or their team. And then they get into the room and they still don't have it. Then the backup plan is to have, let's say, a medical assistant take the 5 minutes needed to administer it. So if it's really important, you can even have that third backstop position to maximize response rates.
Okay, fabulous. Unfortunately, we're running out of time. So there were other questions that maybe email responses can be given to. One thing really quickly is someone asked about, is there a public website where the surveys are published and information on process improvement? And I'll just say quickly, if you go to the CAHPS website, you'll find all those surveys, and there are a lot of other places where you can get PROM data, which we can tell you about if you ask later. And then there's also an improvement guide that's on the CAHPS website. So I think we need to go on to the next slide, if that's all right. Okay, so if you're interested in receiving email announcements about CAHPS news, products, and events, you can sign up by selecting email updates in the top right corner of the AHRQ website. Next slide, please. And if you have further questions or comments, you can email us at caps1@westat.com or contact us by phone at 1-800-492-9261 or visit the AHRQ CAHPS website at www.ahrq.gov/CAHPS. And then the final slide, the replay of today's webcast and the PowerPoint slide deck will be available soon on the AHRQ CAHPS website. You will receive an email with a link to a brief evaluation of today's webcast, and we ask you to please complete that to ensure we can maintain high quality webcast in the future. And this is the conclusion of today's presentation. We're right about at the hour, and I thank everyone for joining, and especially the speakers today. So thank you.